sepsis. So let's talk about it. What is it? So let's talk about the clinical definition first, because we are all clinicians in some variety. So as defined by Singer et al. In the third international consensus definitions for sepsis and septic shock, there is like a whole thing where they meet and they have a conference about how to define sepsis and septic shock. So the third one was in 2016. It is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. And because you are a very smart healthcare professional, you totally understand what that means. But just in case you don't, let's give you the lay definition here, which is that sepsis is a life-threatening emergency. It exists when a person's body injures its own tissues while trying to defend against an infection. So the words here that I really want to point out again, life-threatening medical emergency. What do I mean by organ dysfunction? How can I define organ dysfunction? I'm so glad you asked. Organ dysfunction can be evaluated with a sequential organ failure assessment SOFA score. So I'm going to be calling it SOFA from here on out. You heard me mention that briefly in the SIRS component of this lecture, but it's really more applicable here. So let's talk about what SOFA is, what it means, why we care. So what is the SOFA other than what I told you it stands for? So it's an assessment tool, and it is used to identify the function and performance of several body systems. And this helps us to identify, are all systems go, or is something off in some capacity for one or more of these systems? Very important for us to be able to recognize. And then, if so, how bad is it? How bad is the kidney dysfunction? You know, how bad is the neurological impairment? It will allow us to score that. So why do we care? So first of all, it's going to tell us that there is organ dysfunction, but we know that as SOFA scores increase, mortality increases as well. So there is a caveat to this that I want to make you aware of, which is that a SOFA score is not an individual predictor of mortality. So I cannot say that because you have a SOFA score of 5, that your risk of mortality is 20%. It doesn't work like that. What it does is the SOFA score says, in a group, when we look at all people who are experiencing organ dysfunction, the higher this number is, the higher the risk of death. So we can use that as valuable information, but it's not something where I can give you a specific like point for percentage allocation of an individual person's risk of mortality. But the higher that score is, the more I'm getting really concerned. We've got some really bad organ dysfunction going on. So also, SOFA is not a perfect tool. So you can very easily do a SOFA score on me right now, but if you have a patient who is receiving paralytics or sedation, they're intubated, something along those lines, you're not going to be able to get a fully accurate SOFA score, which is why there's actually something called qSOFA, or the quick SOFA, which is a little bit more direct and to the point and gives us some more valuable information that can typically be, we can kind of figure out more rapidly. It's a good triage tool. The qSOFA is a great tool to use in triage or rapid assessment of a situation. So again, SOFA is a great tool to help us to think about the organ function of our patients, but it's not a perfect tool, and it is not an individual's risk profile. So I just want to make sure we are all on the same page about that. All right. So SOFA scoring, I'm just going to show you the actual table, and I'm not asking you to get in the weeds on this table because there's a lot of information, and this is not something that you would be expected to have memorized. This is something that you would be able to do a SOFA score based on this table being available for you. But just so that you can see it, here's what the SOFA score is. So we're going to be looking at a couple of six different systems here, and you will be scoring the patient from 0 to 4. A score of 0 is normal function for that organ system. So for instance, looking at respiratory system, So we're looking here at the partial pressure of oxygen, the PaO2, and the fraction of inspired oxygen, the FiO2. So we're looking at those things, and we want to see the ratio, and the ratio of the PaO2 to the FiO2 is going to give you a number. So if you divide PaO2 by FiO2, you will get a number, and we want to know, is it a normal number? Is it less than 400, less than 300, less than 200 with respiratory support, or less than 100 with respiratory support? You're going to score your patient. Coagulation, we're looking at how our blood is functioning here. So we want to know the platelet count, and then based on what the platelet count of that patient is, you will score them appropriately. Liver, we're going to look at the bilirubin. So again, we're going to draw that bilirubin level. We're going to look at it and score them based on what this table says. Cardiovascular, looking at the health of the cardiovascular system, hypotension is a very, very big one here. Now, I want you to pay attention to the fact that it is the map that we are paying attention to. So yes, hypotension, I might be able to identify a patient has hypotension when I measure their blood pressure, but I really need to be looking at that map. And we'll talk about calculating map later, but if you took a manual blood pressure, for instance, so you don't have the device telling you what the map is, you can calculate the map yourself knowing the blood pressure. And we'll talk about that in a minute. I want to tell you something that I think is very interesting. If we're in the ICU, you don't need a blood pressure cuff to be taking, the non-invasive blood pressure. You don't need that. You probably have an A-line in place that is telling you beat for beat what that patient's blood pressure is. But if you are in a setting like a clinic, a doctor's office, the emergency room, something like that, maybe you're working in the field in pre-hospital EMS, whatever it might be, if you are using a blood pressure machine, these blood pressure machines actually work by figuring out what the map is and then estimating what that blood pressure, systolic and diastolic, must be to get to that map. Very interesting tidbit there, that because sometimes you'll like measure the blood pressure in some crazy number, and you're like, what? But if you were to take the blood pressure manually and calculate the map, you would find that the map is likely going to be plus or minus about the same. So very, very cool to know that about the non-invasive, the NIBP, non-invasive blood pressure measurement. Now, central nervous system, we are going to assess this with the Glasgow Coma Score. If you are not familiar with the GCS, it is a scale that ranges from 3 to 15 points. You cannot have fewer than 3 points. Very, very important. This table has 3 points. So there is no 0 score for Glasgow Coma Scale, but this is going to be scoring your patient on a couple of different activities. So eye-opening. Do they open their eyes spontaneously like I am doing it? Do they open their eyes in response to verbal stimuli, in response to painful stimuli, or not at all? Then there's going to be a component here about speech. Is my patient conversing with me and they're oriented? Great, they're getting full points. Then we're going to start losing points for things like being confused, inappropriate words, making sounds that I can't understand, but you're making sounds, and then no verbal response. And then we are also going to assess their motor function. So is your patient able to follow commands and move purposefully? Great, they get full points in that arena. If they are able to localize pain, if they are able to, if they have certain posturing, they will have different points for that. If there's no motor response at all, then they will get just 1 point in that category. So we are going to assess the functioning of the brain using using the Glasgow Coma Score. Then the renal system. So how are my kidneys working? We can do either one. We can look at the creatinine by measuring it, by doing a lab study, or we can look at the urine output. Now, urine output is going to be especially helpful in patients who are where I can monitor it very closely because they have an indwelling Foley catheter, and we can do really strict and tight I's and O's for this patient. So I can measure to the milliliter how much urine output they're having per hour. Otherwise, it's going to be kind of a, more of a shot in the dark if this were something like in the emergency room prior to initiation of an indwelling catheter. So these are the organ systems that are measured and how it is scored. Again, I don't expect you to memorize this. I don't expect you to know who gets 0 points, who gets 4 points, that sort of a thing. You're going to have this available for your reference, but I want you to be familiar with it. Okay, we're going to talk about 2 facts and figures that I want you to know. I put them up here on the screen for you individually, so that means that you should probably know them and pay attention. So let's get into it. All right. The assumed baseline qSOFA score for patients without pre-existing organ dysfunction is 0. So it is assumed, because if I have a patient, let's say, that comes in unresponsive, and we're working them up for sepsis, I don't necessarily know what their baseline is, but unless I am aware that they have a pre-existing history of organ dysfunction, like a patient who's on renal dialysis, for instance, a patient in liver failure, unless I know that, I'm assuming that a patient's baseline qSOFA score is 0. So your patient living their life and walking around should have no evidence of organ dysfunction. Here's another important one to know. The acute point change in a patient's consequent to infection that constitutes organ dysfunction. So how many points must I increase to say that this patient is experiencing organ dysfunction? 2 or more. So just like with SIRS criteria, we're saying 2 or more. So, and that means that if I had a patient who came in and I assessed them using the qSOFA score and they had a score of 0, okay, great, they're doing awesome. But then I am taking care of them the next day and they're looking funny to me, something doesn't feel right, and I do another qSOFA score and I realize that now we are at 2 or 3 or 4. That is going to be indicative of organ dysfunction consequent to infection. Certainly there's other things that can change a qSOFA score, like developing renal failure because of, end-stage renal disease. But we're talking specifically in a patient who has infection. So the other important thing to note here is that it's a positive change of 2 or more if the score increases by 2 or more. If the score decreases, I'm not concerned about that at all. That's really encouraging, actually. If the score stays the same, things are staying the same, but it is an acute change of 2 or more points is going to be indicative of organ dysfunction in the face of infection. All right, very important. You got to know these 2, okay? All right, so now let's talk about qSOFA, because this is the one that I do want you to be very familiar with, be able to memorize it, and be able to apply it globally to your patients, whatever your practice setting might be. So here is what qSOFA is and the criteria. So a qSOFA score of 2 or more, again, 2 is this magical number, right? 2 or more near the onset of infection is associated with a greater risk of death or a prolonged ICU stay. So this is what I use as an emergency nurse. This is what I use in triage. When I'm assessing a patient for the first time, I'm looking at SIRS criteria and I'm looking at qSOFA. So let's get into it. All right, so altered mental status is going to get me a point right away. If my patient's mentation is not at their baseline, and that's important too. I can't discount that there are patients who have altered mental status as baseline. But if family says this patient, she's always alert and oriented, she is completely independent, and now she's not making any sense. Again, this could be a lot of things going on, but if I have positive SIRS criteria and now I'm doing the qSOFA, this is going to be a big red flag for me. So again, remember that we assess our patient's nervous system or central nervous system with that Glasgow Coma Scale, so the GCS. So if they do not score a 15, which is a perfect score, if we are at 14 or below, you are giving them 1 point for qSOFA. All right, tachypnea. So again, if my patient has an elevated respiratory rate, but I want you to see here that it is 22 breaths per minute or greater. This is different from SIRS criteria, so I want to call your attention to it. SIRS criteria is greater than 20 breaths a minute. Tachypnea here for qSOFA is defined as greater than 22 breaths per minute. Anyway, if my patient has tachypnea greater than 22 breaths per minute, they are receiving a point for qSOFA. And then, of course, systolic hypotension. Remember, we're trying to think about possible end organ dysfunction. And if I have systolic hypotension, so this would be a systolic blood pressure less than 100 millimeters of mercury, I'm giving them a point. When I cannot adequately perfuse my organs, they will start to fail. So I'm still perfusing, right? Let's say I have a blood pressure of 90/58. Yeah, I'm still perfusing, but it's not perfusing as well as it could be with a better, more adequate blood pressure. So when I cannot meet the demands of an organ system because I am hypotensive, so I cannot get that blood where it needs to go, there's not enough pressure behind the delivery of that blood, we've got a problem. So the organ system is still going to function in some way, but it is going to start to show signs of dysfunction until we eventually get down to full-on failure, and we can end up in, multi-system organ dysfunction and death. So these are warning signs, right? qSOFA, these are the warning signs that something isn't right with our organ systems. Now, if I have positive SIRS criteria, but my patient is mentating great, they are not tachypnic, and they are not experiencing systolic hypotension, they are not meeting that qSOFA criteria for possible organ dysfunction. So I'm going to be a little bit less concerned about sepsis here, right? I'm going to be a little bit more concerned about other sources of positive SIRS criteria. Okay, so what are some findings associated with sepsis? And keep in mind, we're going to talk about a bunch of different things, but I don't want you to forget what we've already talked about, which is SIRS criteria. You are likely to see those manifestations of SIRS in patients with sepsis. So you're likely to see things like a change in core body temperature, elevated heart rate, leukocytosis or leukopenia. You're going to see these markers of SIRS because SIRS is going to be kind of that first response before we end up in sepsis, before we end up with that organ dysfunction, right? So I'm going to see those things. So keep that SIRS information in the back of your head when you're thinking about sepsis, because you are likely to find those as well. Organ dysfunction, like we just said, our patients, in order for them to have sepsis, this means that they have an infection that is leading to organ dysfunction, therefore making this life-threatening. So organ dysfunction. So again, if we have an acute SOFA change of 2 or more points, or if we have a qSOFA of 2 or more points in the face of infection, knowing that we have infection, this constitutes organ dysfunction. And remember that the findings are going to vary based on which body system is affected. If I am septic because of a urinary tract infection, the findings are going to be very different than if I'm septic because of a wound, a cutaneous wound, or if I'm septic because of a septic embolus, or something along those lines. You need to consider that you will see these global symptoms, but organ dysfunction is going to be related to whatever system is affected. So not all patients are going to have renal failure. They might have failure of a different organ system. Not all patients are going to have, failure of their ability to think, of that central nervous system, but maybe they'll experience something else. So just keep in mind that while there are some kind of great things to be on the lookout for, like that qSOFA criteria, not all patients are going to present the same way in terms of their organ dysfunction. And infection-specific findings. Like I said, a urinary tract infection is going to present differently than pneumonia, cutaneous infection, septic emboli, whatever it might be. So you've got to also keep in mind that whatever the cause of the infection is, I'm going to see specific findings associated with that. Yes, I'm going to see those systemic findings. Yes, I'm going to see that organ dysfunction because we are talking about sepsis, but I'm also going to see things related to the cause of the infection. So maybe it is the patient complaining of pain when I pee, or abdominal pain. Maybe it's that I see cloudy, foul-smelling urine when I start that Foley catheter. Maybe it's that the chest x-ray shows us that the lungs are full with infection. So whatever it may be, you're going to see that related to the context of that patient. Okay, now everybody wants to know the workup and treatment. So your patient is sepsis. I think this patient has sepsis. What are you going to do about it? Okay, that's the bread and butter, right? So notify the provider immediately, especially with regards to findings of organ dysfunction. Let's go back to my example. I go to the doctor and I say, hey, this guy is positive for SIRS criteria, but also is meeting 2 or more of those qSOFA, and he's confused and he is hypotensive. I'm really worried about him. I'm going to tell that provider right away. But also, whatever your facility policy is, follow that. Because my facility, we are empowered as nurses to call a sepsis alert overhead in the entire hospital if we believe that this patient meets the SIRS criteria and qSOFA criteria. It is within our scope of practice to call a sepsis alert overhead. And what this means is that it's going to alert people from different departments that this patient needs immediate attention, because remember, sepsis is life-threatening. It is a true medical emergency. So in my hospital, that means they're going to say sepsis alert, ED cart 45, whatever. And then that means that the doctor is going to know, oh, that's my patient. I'm going to know whoever called that. It's going to alert the pharmacist as well, who's going to present to the bedside. We're going to get working on other interventions, which we'll talk about in a second. And we can also be ready to tell the lab, the lab understands now that when blood comes from this patient's room, we got to run it super stat. We got to do this right away because we need to know what's going on. We can also get help from respiratory therapy. And this kind of just gets more hands on deck. So whatever your facility policy is, follow that. Draw those laboratory studies. All patients that you assume may have sepsis or you believe may have sepsis, you've got to draw those labs so we can see what's going on inside. Even if they had labs this morning, everything was fine, and then 10 hours later, they're starting to present funky, I'm repeating these labs because I need to know what's going on right now, not what was going on yesterday or this morning, right? Very important. That's information I want to have, but I need to know right now in this instant what is happening inside my patient's body. Of course, in the emergency room, I have no information. I have no baseline laboratory data, so I need to get this going right away. CBC, a complete blood count, so I can look at the white blood cells, I can look at the platelets, right? Remember that SOFA scoring. BMP, so that I can look at the function of the kidneys, right? I need to know about that creatinine, the BUN. I want to know what's going on for that organ dysfunction. Lactate, I need to know if my patient is in lactic acidosis. We'll talk about that later. CRP, which is C-reactive protein. It's an inflammatory marker. Procalcitonin, this is a newer laboratory study that purports to be able to identify whether or not an infection is likely bacterial in nature. There are positives and negatives to procalcitonin. So I will just say follow your facility policy on ordering labs for these patients. Again, remember that there may be an order set for you where your facility policy says, if you suspect sepsis, you as a nurse may order these things. So go ahead and do that. Get started on that. Assess for other findings. So, or assess the other findings. If my patient is tachycardic, get an EKG. If my patient is having respiratory difficulty, get an ABG. Let me see if I need to be concerned about intubation, protecting that airway, whatever it might be. So whatever those presenting things are, assess it further, right? And then attempt to identify the source of the infection. So sometimes this is going to be really obvious. Sometimes it's going to be the patient comes to the ER and says, I had surgery 5 days ago, and now my wound is red and painful, and there's pus coming out of it. Like, okay, but now I need to culture that wound, right? I need to do urine cultures or blood cultures if I suspect that this patient has an infection. whatever it might be, I'm going to draw those labs, I'm going to send those labs, and then I need to do a thorough head-to-toe assessment. ER nurses, I'm talking to you, a thorough head-to-toe assessment to see if I can identify some sort of source of infection, because again, my patient may not be conscious, they may not be able to answer my questions, so I need to do that thorough head-to-toe, obviously after addressing any sort of life threats. But this is going to help give me some very valuable information about what the possible source of the infection may be. Let me move my head out of the way here for you so we can talk about this last one. I want you to advocate to the provider for early administration of broad spectrum antibiotics, aggressive fluid resuscitation, and any additional supportive care that may be indicated. So if your patient is displaying SIRS criteria and meeting qSOFA criteria, and we believe that there is an infection, even if we have not yet identified it, because remember, it takes time for those blood cultures, wound cultures, urine cultures to come back. So even if we have not identified what the source of that infection is, it is still best practice to begin empiric administration of broad spectrum antibiotics. Empiric meaning I don't have the data to prove that you have an infection, but you look like you have an infection. So based on the data that I do have, I'm going to treat you empirically with these antibiotics. Lastly, when we are talking about sepsis, I want to bring up to you this idea of aggressive fluid resuscitation. So when we are dealing with sepsis and the potential for end organ dysfunction, we need to get that blood pressure up to make sure that we are adequately perfusing. And there's a magic number that I want you to learn and memorize it and be ready to use it in clinical setting, which is the magic number of the IV fluid bolus, the initial IV fluid bolus. So this is not dealing at all with maintenance fluid. This is talking about the initial IV fluid bolus for your patients with sepsis should be delivered at an amount of 30 milliliters per kilogram. So this is the magic number. So you will see orders come in for really weird amounts, and you'll be like, that's a very specific amount. Why did they order 2,070 mLs and not, 2,000? Like 2 liters. So things like that will come up, and this is why, because we do this 30 mil per kg IV fluid bolus for patients in sepsis. This is what I'm talking about when it comes to aggressive fluid resuscitation and advocating for that as the nurse. So if we'll go back a little bit here, we were talking about advocating for early administration of broad spectrum antibiotics, but also going after that aggressive fluid resuscitation. So that is what we need to be doing here. We need to be talking to that doctor and saying, hey, this patient looks like they are in sepsis. I've done this, I've done that, I've sent these labs, however, can I get an order for a 30 mil per kg IV fluid bolus as per the recommendations for treating sepsis? So that was a lot of information for you there on what sepsis is, what it isn't, how we identify it, how we manage it. And so I want to give you a few quiz questions to test your knowledge of what we just went over. So go ahead and do that, and I'll see you in the next one.
Question 1. What is the recommended milliliters per kilogram bolus for fluid resuscitation in patients experiencing sepsis? The answer is 30 milliliters per kilogram. Number 2, which of the following are components of the qSOFA tool for organ dysfunction? Select all that apply. A respiratory rate over 22 breaths per minute. B, a temperature over 38 degrees Celsius. C, a systolic blood pressure under 100. D, a Glasgow Coma Scale score under 15. And E, a heart rate over 100 beats per minute. The answer is A, C, and D. Heart rate and temperature are components of SIRS, but not qSOFA. Number 3, do the following assessment findings meet the definition for organ dysfunction using qSOFA? A pulse of 120 beats per minute, respirations of 24 breaths per minute, a blood pressure of 109 over 82, and a Glasgow Coma Scale score of 15. The answer is no. The patient does not meet the qSOFA criteria for organ dysfunction. The patient has a respiratory rate over 22 breaths per minute, which meets one criteria. However, a patient is considered to have organ dysfunction if two or more criteria are met. We invite you to subscribe to our channel and share a link with your classmates and friends in nursing school. And if you found value in this video, be sure to hit that like button and let us know what you found to be particularly helpful.